Hi everyone, welcome to today's episode of the REFERROLOGY series. Today we are very privileged to have Dr. Leonard, who's a neurologist and a stroke specialist, to talk to us about stroke disease. So let's dive into our case scenario. Mr. Tan is a 60-year-old gentleman. He's a smoker of 40 pack years and has background hypertension and hyperlipidemia. He presents with sudden onset left-sided weakness associated with slurring of speech, and he only noticed the symptoms when he woke up in the morning at about 7 a.m. and had gone to bed well the previous night at about 9 p.m. On examination, he is noted to have a right-sided facial nerve palsy with dense left-sided hemiparesis with power 1 out of 5 associated with reduced sensation on the left side. So the first question I have is, when do we call for stroke activation, given that we know that the window for activation is increasing currently in the context of EVT?
Yeah, so that's a very good question. In the past, it used to be for intravenous TPA was 4.5 hours, and now even with if you do a perfusion scan, you can even lengthen up the IV TPA window to 9 hours. And some people say if you have salvageable tissue, timing doesn't matter. But I think for practical purposes, any a large vessel occlusion, from 6 to 24 hours, you will need a CT perfusion or MR perfusion scan to show that there's salvageable tissue. So anywhere within 24 hours, if you can arrange a perfusion scan and the patient seems to be a good candidate, you can call for stroke activation.
Okay, so basically in the current context, if there's any doubt, then we'll probably err on the side of caution, and if it's within the 24-hour window, we'll still get the stroke specialist down for a review. Is that correct?
Yes. Yeah, so it's getting more and more headed in that direction. So the main thing is whether you can arrange, whether the patient is suitable or not. For example, if the patient is previously wheelchair bound or bed bound, then there's not really that much to save. But if the patient is a young person, even if the stroke happened 23 hours ago, I would still ask for CT perfusion.
Got it. So this brings us sort of to our next question of the initial brain imaging. So we are familiar that most of the time a plain CT is done up front to exclude any hemorrhage. The next question is, when do we need to do a CT angiogram up front? And you also mentioned further tests such as perfusion imaging. So how do we decide on these modalities?
At the point of emergency care, it's quite straightforward. You do need a CT brain because a plain CT brain will help you to rule out bleeding. It's impossible to use physical examination to rule out a bleed.
Yep.
So both a bleed and a stroke will present the same way. So you need a plain CT scan. The next step is you need a CT angiogram because you want to look for a large vessel occlusion, and that is amenable for thrombectomies.
Yep.
So large vessel occlusion is anything in the middle cerebral artery, the internal carotid artery, or in the basilar artery. If it's large,
the CT angiogram will be based on your findings of the plain CT. Is that correct?
No. So at this point in time, we do not wait. We do a CT scan. Sometimes we pause and give the TPA bolus, and then we immediately move on to a CT angiogram. We tend not to wait or decide on the plain CT findings. We tend to just go ahead and do the CT angiogram, unless the patient has we know that the patient already has a lot of renal failure and is at risk of contrast nephropathy. Then there's a reason to hold off a CT angiogram. Having said that, if it's a large stroke, we use a scale called the National Institute of Health Stroke Scale, which is basically a scale from 1 to 40 plus, which it's meant for dummies. So the majority of the deficit is in the upper limb and lower limb weakness. So 5 points at upper limb is considered a large stroke. So you can imagine, as long as you have a arm that cannot move or a leg that cannot move, it's considered a large stroke, and therefore it's amenable to a thrombectomy. So very seldom we wait for the plain CT. We just go ahead and do a CT angiogram.
So the only instance where you probably won't do if the deficits are extremely mild, like let's say the power is like 4+, that kind, with minimal other symptoms.
Okay, so to make things even more confusing, which is not the purpose of this, I know, is that even for mild strokes, 30% of them, or 1/3 of them, go on to become dependent on for care.
Yeah.
So that being the case, I think the easiest way to think about it is if there's a large vessel occlusion, even if there's a mild stroke like an NIH of 3 or 4,
yeah,
we will still go in and do a thrombectomy. So unless the patient has, let's say, like just a facial droop or maybe just ataxia,
yeah,
we will still do the CT angiogram.
got it.
One particular scenario is that if the patient has an NIH of 1 or 2, but is aphasic and has a large vessel occlusion, even with such a small NIH, because we consider aphasia very disabling, we will still go ahead and do a thrombectomy for the patient.
Understand. Okay. The next question would be, you mentioned about perfusion studies. So when do we need to do perfusion studies in addition to the CT and the CT angiogram?
So they're commonly done in one shot altogether. The short answer is anything within 6 to 24 hours,
Okay.
CT perfusion is necessary. Patients who have woken up with an unknown time of onset, that's also another reason to CT perfusion.
I see. So I was looking through the stroke guidelines, and it did mention that using MRI, where you compare the flare and the DWI, that can give you an idea also of the ischemic penumbra. The reason why we do perfusion study here, is there a logistical reason, or is a CT perfusion better than MRI in determining the salvageable penumbra?
So it's a CT perfusion is a surrogate. It's an estimate. MRI is more accurate because what you're looking for is the DWI, which is the diffusion weighted image.
Yeah.
That is typically considered the amount of unsalvageable tissue. Anything more than 70 mils, people don't do so well. Then in the trials they rule them out of thrombectomy. Anything less than anything more than 50 mils is already halfway bad already. So DWI is more accurate. The problem is that it takes time to do a MRI. Even in the centers which are streamlined for MRI, they can do it within about 10 to 15 minutes.
Okay.
CT perfusion and CT scan takes about 5 minutes. So in our center, in fact, 80% of the world, they do CT perfusion. Only the very rich centers, they do MR imaging.
Okay, understand. The next question I have is this thing about aspect scores. What exactly is the aspect score and how do we use it?
Okay, so the aspect score is an Alberta scoring system. It comes from Canada. It just divides the MCA region into 10 parts. If you Google it, you can actually see it. And it's basically just a surrogate score to figure out how much of the MCA is involved.
Yep.
So the basal ganglia, which is divided into 3 parts, and the cortex are divided into 6 parts. And finally, the insula is the last part. Usually, this whole thing came from the past where for intravenous TPA, if you give it in a very large stroke, which is considered more than 1/3 of the MCA, there's a high chance of bleeding.
Okay.
And that was a relative contraindication. So therefore, an aspect score of 7 or less, 7/10 or less, it's considered more than 1/3 of the MCA, and therefore not so great for IVTPA.
Understand.
At the same time, if it's a large stroke and you already see it on the plain CT scan, then that tissue might be unsalvageable. So you can use your aspect score to figure out whether you actually be treating with IVTPA or thrombectomy or not. Less than 6/10 it's a gray zone. Less than 4/10, most people will not try to do a recanalization or a thrombectomy.
Okay, understand. Thank you. So next, we move on to talk about thrombolysis. Could you give us an overview of the indications for thrombolysis? That would be the first question.
Sorry, could you repeat that again? I couldn't hear you.
Indications for thrombolysis. Okay,
so anything, as long as it's not a bleed, a lot of times we can do we can get thrombolysis. One of the major reasons why people are afraid to give thrombolysis is because of the bleeding risk, which is about widely quoted to be about 6%. If you do not have a stroke, actually, and your tissue is not infarcted, the risk of bleeding is very small. So thrombolysis is pretty safe if there's no stroke and no other source of bleeding.
Okay.
So the indications is basically anybody with ischemic stroke, first of all. CT scan needs to be done to rule out bleed, and then if you are confident that stroke based on your history and physical examination, you can actually go ahead and give the IV TPA.
And the time window is less than 4.5 hours, is that correct?
It's 4.5 hours if you do not have a perfusion scan. If you have a perfusion scan and the salvageable tissue, so in places where there's no
Sorry, I didn't catch that part of the audio. Sorry, it dropped off a bit.
Okay, I think sorry, what was the question again?
Sorry, I think you were mentioning that in some parts of the world, then that part, the audio dropped off a bit.
Okay, in some parts of the world, where you're not able to do a thrombectomy.
Yeah.
If all you have is TPA,
yeah.
Then if you do a CT perfusion and it shows that the infarct size is small,
yeah.
and the salvageable penumbra is big, you can actually still use TPA to treat, even if it's after 4.5 hours. 6 or 9 hours, you can still do that.
Understand. I think you've sort of answered the second question about threshold to give, because in some patients there's suspicion for non-organic paresis, but you did mention that if there isn't actually a stroke happening, the risk of bleeding is fairly low.
Yeah, I tend to err on the side of I tend to be more reckless if I think that there isn't a large stroke and the patient doesn't have any risk of bleeding, because the idea is very simple. If you have a infarcted tissue, the blood vessels become very friable.
Yeah.
However, if you do not have any infarcted tissue, what happens is that the TPA just circulates around your system, and after a half-life it disappears.
Okay.
And therefore it's quite safe. So they actually gave TPA wrongly. They looked at a series of about 600 patients where they gave TPA wrongly, and only 2 of them bleed, so the risk is less than 1%.
Okay. And what and how do we monitor patients after thrombolysis? Perhaps both in an overnight on-call setting and subsequently, like whether you repeat a CT brain routinely.
Okay, so that part is pretty important. So first of all, it needs to be in a high dependency setting, because you're worried about the bleeding risk. The blood pressure is important because the blood pressure is directly correlated with the risk. So we try and keep it below 185 over 110. Some people, I personally keep it lower than that, about 150, 160.
Okay.
If I've already removed the clot and I know the vessel is recanalized, I drop the pressure to about 120 or 130 systolic. Watch for any bleeding risk. If there's a drop in NIH of more than 4 points, then he needs an urgent CT scan. Or even if you're worried that the patient neurologically is deteriorating, I have very low threshold to repeat the CT scan to look for a bleed.
Okay. And if let's say the patient remains stable in terms of the neurology, would we then do a routine repeat scan like 24 hours later?
So that is part of the protocol around the world, that at 22 to 36 hours after IBTPA or even after a thrombectomy, we do a repeat CT scan. That helps us to guide the antiplatelet.
Sorry, you mentioned the audio dropped off a bit again. So you mentioned that helps you to guide the antiplatelet therapy, is that right?
Yes.
Okay.
Antiplatelet therapy, and as well as how to prognosticate the patient after that.
Okay, understand. Thank you. Next, we'll move on a bit to EVT. So I think the recent years, there's been a lot of emerging evidence. We are pushing the time periods. And I think amongst the juniors, it's a space that we may not be so familiar with because it wasn't really taught a lot in medical school. Maybe you could give us a bit of an overview of the recent evidence. When should we be doing it? And finally, how do we monitor patients?
Sure. It all became very popular in about 2015, where there were a lot of 5 trials that actually showed that there was huge evidence for thrombectomy. So to give you an idea of how powerful it is, the number needed to treat is 2.6, which is the strongest modality you can use for treatment in medicine, actually. So for cardiology, it's like 1:35. For pneumonia, it's 1:30. The number needed to treat. So for antibiotics, so this is a very strong thing. What we do is anywhere within 6 hours, as long as there's a large vessel occlusion, we can go in and pull out the clot, and it shows that there is improvement in both mortality as well as the patient outcome. If you can do a perfusion scan, you can stretch this, like we said, up to 24 hours. And the 6 to 24 hours trials actually do show that there needs to be a small infarct and a large penumbra, and usually also a large accompanying deficit. So the way they structured the trials was that if you have a high deficit and small stroke, you can go in and pull out the clot.
Okay. In terms of practically, so I understand that we give the TPA, and if they are candidate for EVT, we proceed with the EVT straight away. Is that correct?
Yes,
So we do
that's correct.
thrombolysis and EVT back to back.
Yes, 10% of the actually it's quite common that you see a patient who has IVTPA brought to the angio suite, and then the vessel is actually recanalized. So it happens in about 8% to 10% of it. But we don't wait because time is brain. So we give the TPA and we rush the patient to the angio suite. If the faster you can pull out the clot, the more brain you see.
Okay. And in terms of post-procedural monitoring, is there anything in addition to thrombolysis therapy that we need to monitor with regard to these patients?
Not too much actually. It's just that it's good to know if the vessel is actually recanalized or if there's any thing left over. So there's this scale called the MTK scale, which is a modified thrombolysis in anything less than 2B is 50% recanalized, 2C is 90% or almost completely recanalized, and 3 is completely recanalized. So if you look at your notes and you see there's 2, if it's 2A or less, you know that it's not a very successful thrombectomy. Then you might want to let the blood pressure be higher so that the collaterals can try and perfuse the area that was not recanalized. Okay. Having said that, you must bear in mind the bleeding risk. If it's already a 2C or 3, you probably want to drop the blood pressure more because you are afraid of bleeding, and honestly, there doesn't need to be very high pressure to reperfuse the area that's already recanalized.
Okay, got it. So if it's like a 2A, 2B, then your pressure targets would probably be like 150s, 160s thereabout. And if it's
I would say that is great for 2A. For 2B already, I would drop it to about 140, and 2C or 3, I drop it to probably 120, or not just normal tensive.
Okay, sure. Thank you. Okay, so the next question is about antiplatelets, and I think this is something that confuses the residents quite a bit. So I guess the scenarios we get, I mean, it's quite straightforward. If this patient has not been on anything, then we normally choose to start, let's say, like aspirin. But patients who are on something already, on DAPT already, so how do we navigate this space?
That's a difficult question, okay? Actually, there's a whole plethora of trials out there. So aspirin, which we're all very familiar with, is the gold standard. Number needed to treat is about 111 to save for one person to benefit.
Yeah.
Clopidogrel or Plavix, the number needed to treat is 50, which is definitely better than aspirin. The problem is that up to 10% of patients have in the Caucasian population have resistance, and we do not test for resistance. In Asian patients, it's supposed to be higher, but the data is not very good. So if you give clopidogrel, you do not have your GI problems, but you may not be doing much work. You may not be doing very effective. Ticlet is as effective as clopidogrel. Number needed to treat is also about 1:50. However, it has a risk of agranulocytosis. You can drop your counts, and because of that, it's fallen out of favor. Then there are others. Prasugrel has a higher risk of, because of the Triton 38 trial, which was actually a cardiac trial, but it shows that there's a high risk of bleeding. So it's contraindicated if you have a heart attack or if you have a stroke or TIA, prasugrel is contraindicated.
Okay.
And finally, now we're coming to ticagrelor, which is supposed to be a stronger P2Y12 inhibitor, but it's expensive, and the evidence is almost there, but not quite yet. So, to summarize this, I would say that you have to match it to the patient. So if it's a naive, if the patient has a high-risk TIA, or the patient has a mild stroke with not much risk of bleeding, or the patient has a large vessel of stenosis, then dual antiplatelets might be better than single antiplatelets.
Okay. And in terms of the DAPT duration, because I understand for the high-risk TIA or the mild strokes, then we have the chance and point trials where the duration of the DAPT is actually fairly different. So how long do we give the APT for these patients?
So the China trial came first, and it was a China trial, and
Yeah.
it shows that if you carry on if you give it for 3 weeks, there's a benefit, and then you drop it to a single antiplatelet.
Yeah.
So the point trial came about because I think the Western world didn't believe the Chinese trial, and they did their own trial. And the thing that they did was they continued the double antiplatelet for long term, and it shows that there's a higher bleeding risk. So which goes to proves that if you need to tailor your medication to the risk of the patient. So the risk of the patient with a stroke to get another stroke is highest right at the start. So you need to hit hard. And once the risk of a stroke comes down, you want to reduce the risk of bleeding from your antiplatelet. So you should drop to a single antiplatelet. So I think we usually tend to give 3 weeks to 1 month of double antiplatelet followed by single antiplatelet.
Okay. What about ICAT? Do we tend to give it for the same duration?
Okay, so ICAT, again, there was a trial for Sampris where it was stenting versus best medical treatment. And in that trial, they actually called the patient to make sure that they took their medication. So dual antiplatelets for ICAT for a longer period is fine. But for the trial, they also did many other things that ensured that they had a very good outcome with the best medical treatment. They made sure the patient exercised. They called the patient to check their blood pressure. So that was a very well done best medical treatment. To summarize, I think in ICAT, dual antiplatelet is probably more useful, and I would maybe give it up for 3 months, but this is very arbitrary.
Sure, understand. And I'm not sure whether you mentioned just now because the audio dropped a bit, but let's say the patient is already, let's say, on aspirin or on Plavix and then strokes out on that single agent, would you then normally switch the agent? Is there benefit in that?
Okay, so there's no evidence. We tend to do it because we feel like we need to do something for the patient, and switching from one to the other seems to be makes everybody feel happy. You actually feel like you're doing something.
Sure.
I think that if the patient was on a single antiplatelet and has a stroke, then we need to look at the underlying cause of the stroke. So if it's previously it was thought to be a lacunar stroke, and then now we see that now the patient has atrial fibrillation, then there's a reason to switch to double antiplatelet or anticoagulation accordingly. If it's a lacuna and the diabetes is not well controlled and the blood pressure is not well controlled, switching the antiplatelet actually doesn't really do very much good. But you can switch it if it makes you feel better.
Okay. And the last question about antiplatelet therapy is the timing of initiation after thrombolysis or EVT. This would be based on, like you mentioned, like how well canalized it is, right? There's no hard and fast rule as to when we start the antiplatelet therapy. Is that correct?
Yes. Basically, you're trying to balance the risk of the benefit versus the bleeding risk.
Sure.
If the patient has recanalized and there's very little tissue has infarcted, then your tightrope is huge. It's easy. If the patient has not recanalized but there's a large infarcted tissue, then your tightrope is very small, and then it's very difficult to do. So it all depends on the follow-up scan and whether the vessel is open or not.
So for the practical thing for the residents would be not to start the antiplatelet overnight, and then in terms of when to start, check with the stroke consultant.
I think generally you are seldom wrong. Just look at the CT scan. If the CT scan is a large stroke, you probably want to just give a single antiplatelet, and in the morning the consultant can decide himself to add to a dual antiplatelet if he had forgotten to give an antiplatelet even after the scan comes out.
Okay.
But if there's a bleed, then obviously you probably hold off and wait for the guy to decide on his own.
Sure, understand. Thank you. Okay, next is about patients with, let's say, dual pathology in terms of the underlying etiology. Let's say they have ICAT, very pronounced atherosclerosis, at the same time also has atrial fibrillation. Is there a role for like anticoagulation and antiplatelets for these patients?
So it's been shown that the risk is higher if you anticoagulate and give antiplatelet. So in the past, currently we only advocate it for patients who have a stent, because the antiplatelet helps to keep the stent open. But then if they also have like AF or even an LV thrombus, then they need the anticoagulation as well. So in these conditions, we don't really have much choice. We have to subject them to both and accept the higher bleeding risk.
Yeah.
Having said that, we're moving to a new era. There's a trial called a COMPASS trial, which shows that if you have vascular problems in two vascular trees, either the brain, the heart, or peripheral vascular disease, you can give low dose rivaroxaban and aspirin, and it seems to have a benefit. But this is not done during the acute period. This is done 1 month after the acute period.
Okay.
So it's this low dose DOAC plus antiplatelet plus aspirin might be coming around the corner very soon. Becomes more and more common actually.
But at present state, what we would normally do is like if there is like AF and let's say ICAT, you would normally just anticoagulate the patient during the immediate period. Is that correct?
Yes, only if there's a stent, then we have no choice. They're antiplatelet.
Okay, thank you. So the next question is about statins. I think the first question is timing of initiation. Does it need to be started like overnight immediately? And NUH has this slightly interesting practice of like very high doses of 80 mg atorvastatin for 5 days and a subsequent de-escalation of the dose. So maybe you can talk about timing of initiation and then this.
Okay, so it's atorvastatin 80 milligrams because there's only one trial, randomized controlled trial of statins in acute stroke, which is the SPARKLE trial, which shows the benefit, no mortality benefit, but there's a benefit with high dose atorvastatin 80 milligrams. So we don't know if Rosuva or simvastatin actually helps, but we do know atorvastatin helps.
And how long did the trial give the 80 mg atorva for?
Yeah, so it gave it, it just gave it long term. Okay, so the reason why you see a lot of 80 milligrams and downgrade quickly is because it ties into your first part of the question, which is, do you give it acutely? So there's this belief that atorvastatin is a plaque stabilizer. So let's say that you have a plaque that ruptured and causes a clot to form. So atorvastatin helps to stabilize that plaque so that it does not rupture any further. So acutely there is some benefit.
Okay.
It's thought. However, in Asians, there's a higher incidence of muscle problems with atorvastatin. We give 80 milligrams, we see a large proportion, even up to 15 to 20% of them actually have raised CK, and LFTs can also be raised. So in that case, we drop it. So this is against the evidence. The evidence actually should be 80 milligram all the time.
Okay.
Long term.
So it's sort of a bit of a contextualizing to your local population, and therefore we do this like middle ground kind of thing.
Recently, okay, so then the target for your lipids is also a bit odd. In the past, we used to say anything below 2.6 is fine. Then the data from the heart direction says that as long as you, after acute episode, as long as you drop your LDL 50% from your initial, it's fine.
Yeah.
But now there's new evidence that says actually you should be targeting 1.8. So nowadays we tend to give it atorva 80 milligrams, drop it to below 1.8. In the chronic phase, we sort of target 1.8 and adjust accordingly.
Okay, understand. Thank you. So the next question is about IV hydration. Firstly, how much do we hydrate and what is the drip of choice? And how long do we need to keep patients on IV hydration for?
Okay, so this one is very simple. Don't give dextrosaline. It's unless you have to, because it's associated with worse outcomes. IV hydration, you can give anything you want actually.
Okay. Dextrosaline because of the risk of
if the patient has relapse.
Okay.
Yeah. Otherwise, if the patient has no low ejection fraction, there's no history of CCF, then give anything you want actually. There was actually a trial where they tried to flood animals with fluids to see whether it improved them, and because of the homeostatic mechanism of the brain, all the fluids ends up in the lungs, so it doesn't really work very well. We give 1.5 liters as an arbitrary amount to keep the vessels open, but honestly, if there's no contraindication, you can give whatever you want.
Okay, and normally we give it for how many days?
Yeah, so that's also arbitrary. So if the patient can drink, theoretically, he doesn't really need hydration. But if there's stenosis, we think that it keeps the vessel open. So we give 1.5 liters for 1 or 2 days. It's arbitrary. There's no real hard pass through.
Okay. And even for patients who have like completely recanalized following a thrombectomy, would still give a short course of IV hydration?
Yes, but there's no evidence for that one way or the other.
So the idea mainly is to just improve the perfusion.
Keep the vessel open, improve the perfusion. Yeah, basically.
Thank you. So maybe we could just have a short word about the different blood pressure targets in different contexts. You have mentioned the blood pressure target following thrombolysis. What about instances of, let's say, patients who were not thrombolized? And are there any other special scenarios that we need to consider?
Okay, so data about this is there's a lot of debate about what you should be targeting in your blood pressure. After day 2 or day 3 is quite clear. If there's no large vessel stenosis, you can actually drop your blood pressure to less than 140 quite comfortably. Within the first 2 to 3 days, I think it's very common sense because the evidence is all over the place. If there's large vessel stenosis, we have this thing called permissive hypertension where we keep it open. In fact, if the vessel is very tight, we even give permissive hypertension for a few weeks. If not, there's actually if there's no large vessel stenosis, there's a J-shaped curve where anything less or more than 150 or 140 mmHg seems to be associated with a worse outcome. So, to put it in practice, I don't really worry about the blood pressure too much in the acute phase. I just drop it below 200. In the chronic phase, I tend to control it. Then I focus on it because the number needed to treat for treating blood pressure is 10. So it's even if you don't give any antiplatelet, you don't give any statin, blood pressure alone will prevent more strokes than both of them combined.
Okay. And in instances where you want your blood pressure a bit lower, like you mentioned, in instances like after EVT where it's well canalized, and let's say the patient's BP is ranging at, let's say, 180s, 190s, and you want to bring it down. How aggressive are you in these instances? Do you give IV medications, and what is your preferred medications of choice to bring the blood pressure down the acute setting?
Yeah. So if I know the vessel is recanalized and I'm sure it's not reoccluded, and the blood pressure for some reason is stubborn, I drop it very aggressively. So usually I'll try a GTN patch and an oral agent first. If it doesn't work and it's constantly hung up at 180, then I hit it with either IV GTN or IV labetalol, depending on the heart rate and the underlying cardiac condition.
Okay, understand. And in normal instances, let's say there isn't, okay, so maybe for both, if there's large vessel disease and there isn't, when do you normally commence the antihypertensive agents when the patient is admitted? Is it like day 2 to 3, or there's no hard and fast rule with regard to this?
So usually I do not worry too much about it. I just, by day 3, I start checking to see whether the blood pressure is under control.
Okay. Then that's when you start adding your antihypertensive agents, if let's say.
Yes. In the meantime, as long as you keep it below a reasonable amount, like I said, 200 or 180, I'm quite happy. But once the patient has been here for 3 days and there's no large vessel stenosis, then I start to really look at the chart and make sure that it's below 130, 140.
Okay. The next is about SSRIs in stroke. So I understand that there are some pockets of evidence. What's your take on this?
Yeah, this is tough now. So when I was registrar, the fluoxetine has a benefit in stroke rehabilitation, and then recently these guys come up with this trial called Focus trial, which shows that it doesn't have a benefit. The Flame trial is quite small. It's like a few hundred or 200 patients are recruited, whereas the Focus trial is like, I don't know, a couple of thousand patients. So you would think that you should trust the Focus trial, but the Flame trial uses a scale that is mainly deals with motor symptoms. The Focus trial just uses a modified ranking scale. Modified ranking scale is basically a 0 to 6 scale, where 6 is dead, 3 uses a walking stick, and 0 is normal. So they're measuring different things. I think the bottom line is that we don't really know at the moment. However, fluoxetine seems to be useful to reduce depression, and it might be better for motor recovery. So if the patient is depressed, no problem, or the patient is going to be depressed, no problem, just go ahead and give. There's not terribly a lot of side effects except watching your sodium. But if let's say like the patient has difficulty walking or just needs a little bit more motor symptom improvement, then fluoxetine might be useful. There's some new trials coming out from Sweden and somewhere else, I think Holland, where they are actually looking at the same thing. So once they add all these trials together, and they should be able to rule one way or the other whether it's useful or not useful.
And if you do you start it inpatients, outpatients? How early should it be?
I tend to start it inpatient because I find that that's the max. In my mind, that's the maximum benefit that they derive when they are actually getting back their initial function, and that's when they are most depressed.
Okay,
There's no real good evidence for this.
okay, understand. So next question is, sometimes in our patients who are admitted, we notice that there is some element of fluctuating neurology, and sometimes as residents, we don't know when is it significant, when do we need to rescan, and what are the things to consider when there's fluctuating neurology. So could you take us through this?
Okay, so this is difficult because a lot of times the neurology is a very general term, and sometimes they fluctuate because they are septic, sometimes they fluctuate because they are sleepy,
Yeah.
or sometimes they fluctuate because they are medication. But let's say like the power is fluctuating,
Yeah.
or the consciousness is fluctuating. In these two circumstances, if the patient already had a stroke, if it's on the same side as the previous stroke and it's just acutely, generally speaking, you have to look at the notes. If the vessel is recanalized already, I would order another scan to make sure to see whether the vessel reoccluded.
Okay.
But if the vessel is already occluded, or we had done nothing to recanalize the vessel, then the other thing you worry about is it's a bleed. So then a plain CT scan will be useful. I have a very low threshold for ordering a plain CT scan when I find that the patient's neurological features are fluctuating.
Okay. But apart from a bleed, apart from a reocclusion, it is also possible that just the inherent disease that has occurred can also cause some fluctuation.
I think it's better to, if it's just the evolution of the stroke, then there isn't very much you need to do. What you want to do is you want to catch the patient when, for example, you're giving antiplatelet and the patient had a bleed, or you're giving anticoagulation and the patient has a bleed. That's when you want to stop it so that it doesn't get worse.
Okay, understand. So the next question, as we talk about the etiological evaluation later on, I think one of the questions I have is how reliable is the clinical presentation to the etiology, i.e. some patients appear as a subcortical stroke based on clinical phenotype, but does it always correlate in terms of the anatomy?
Okay, so it correlates more often than it doesn't actually. The reason why it doesn't correlate is because we don't do our physical examination properly.
Okay.
Actually, so to be honest, it always starts from history and physical examination where you diagnose. If you pick up one of the lacuna syndromes and you do a scan, very often you will find that on the scan there's a lacuna syndrome, and the next step is to make sure that there's no large vessel occlusion. And once all of this is in a row, then you know that you have figured the patient out. It's only when it doesn't correlate, then you need to look further. So I would say most of the time it does correlate. 80 to 90% it correlates. And the time that's, for example, let's say like you get a aphasic patient, and on the scan it's just a lacuna stroke or no stroke at all. That's when you actually need to really investigate and figure out what's going on.
Okay, and this leads into the next question about firstly vessel imaging, and then we talk about cardiac imaging. So in terms of vessel imaging, then do all patients with a stroke, regardless of whether it's a small stroke, big stroke, require both evaluation of the intracranial and the extracranial vessels?
So the short answer to that is yes, because you want to figure out what's going on. And if you find a stenosis intracranially that doesn't, because they're the same vascular tree, there's often a high chance of you getting a stenosis extracranially as well. Okay. So generally you want the whole vascular tree from the aorta all the way up. As to which to use, MRI, MRA is the most expensive, but if you're doing MRI, you should do MRA. Okay. MRA tends to overcall the stenosis, so you got to bear that in mind. Okay. CT angio is the best modality, I find, highest resolution, but it's got risk of contrast nephropathy, so you can't use it in patients with renal problem. And TCD, ECD is cheap and fast, and we trust our sonographers, so we do a lot of that. But to cut a long story short, I would say yes, you should do vascular imaging for every patient who you think has a stroke.
Okay, even if it's like subcortical looking kind of stroke.
Because like we said, it may be subcortical looking. On the scan, CT scan or MRI, it might be subcortical. Or occlusion that changes the dynamics completely.
Okay, sure. So the next question is diving into practicalities a bit, because some patients, let's say, are there instances where, let's say, you have done a CT angio already, but you still need to do a TCD or ECD, i.e., based on my understanding, one is a luminogram and another is a bit of a functional kind of study.
Exactly.
are there instances where, let's say, you have already technically done the evaluation, but imaging evaluation may not be adequate, you need a functional evaluation, or vice versa?
Okay, so that happens quite commonly
Okay.
for two reasons. One is, like I said, if you have an intracranial stenosis, but you do not, on the CT angiogram, it looks like there is a stenosis, but you do not know how bad it is. PCD will be able to tell you how much blood flow is actually getting past. Similarly, sometimes you get a stenosis on the CT angiogram, and you want to find out whether it's from a dissection or whether it's from arteriosclerotic plaque or vasculitis. Then a vessel wall MRI will also help. So a lot of times we do multiple modality imaging to figure out what's going on.
Okay.
Not uncommon.
Okay, understand. The next is about cardiac evaluation. So do all patients need an echo? And then, other things like telemetry, how do we navigate this space?
Yeah, I find we order a lot of echoes, which is we should be more circumspect actually, because there's quite a lot of studies that show that if you indiscriminately do an echocardiogram on everybody, it doesn't really show up. It's not very useful. It doesn't really show up much pathology. So it should be very targeted patients. So you want to see. So you want patients who have who you think are cardioembolic source, or you think that there's something wrong with their heart. Maybe when you came in, you screen your chop, or the ECG looks funny, then sure, there's a reason to do an echo. But from a stroke perspective, if you look at the CT scan or the MRI and you see wedge-shaped infarcts or infarcts in multiple territories, then you'll worry about cardioembolic source. Because when an echo is useful, in fact, if we had the ability to, either a CT or MRI of the heart would be even better to look for any abnormalities, because those show up thrombosis as well as structural abnormalities better than the echo. But echo is the fastest modality that we can get, so we do echoes.
Okay.
I see you mentioned bubble studies and telemetry. So bubble studies, basically you're injecting bubbles of normal saline and air into a vein, and you put an ultrasound probe at the blood vessel of the brain, and you're trying to see whether the bubbles actually hit the brain. Most of the time they get lost in the lung circulation, but if you have a right to left shunt, it will actually go up. And since if you have a bubble that goes from the peripheral circulation to your brain, then it's a very likely path of causing a stroke. So it's been reported. So we do it when we think that, especially in young patients. If we see embolic, we see embolic pattern of stroke in the brain, but the heart doesn't really show that much of an embolic pattern. Then we focus on this. So if your bubble study is positive, then it behooves you to hunt for an underlying cause of clot formation, whether it's coagulopathy or DVT or something like that.
Okay.
And then if you actually find both, then you might want to close the hole in the heart. Telemetry is you're looking for same thing. The brain scan shows embolic source. You're looking for atrial fibrillation. So there are a lot of studies out now, but basically 48 hours of telemetry seems to be the bare minimum. Nowadays we're moving on to 1 week or even 1 month, and some people say that the longer you do it, even better. Sure, there's diminishing returns, but if you just do one snapshot ECG, the number of AF you pick up is 1.17%, whereas if you do it for 30 days, it goes up 12%. So there's really a big push to do as long cardiac monitoring as you can.
Okay, but once again, how aggressive you are would depend on the clinical context. Patients who look very cardioembolic, then you would probably hunt them longer for AF. Unless if it's very clear-cut microvascular, then probably we may just do with the 48 hours of
so like you're correct. So if it's a subcortical stroke or a small infarct, I may not even want to do telemetry. Actually, I would not want to do telemetry. I think it's wasting resources. But if you see a wedge-shaped infarct in the brain, or you see multiple embolic strokes, I cannot, and your vessel scan of your neck and your brain doesn't show any stenosis, then I hunt very hard for cardioembolic source.
Okay, got it. So the next question is about hemorrhagic conversion, or sometimes when we do MRIs, then there's reports, then it may be reported that there's some hemorrhage seen. So the question is, when is it significant, and when do we need to hold off antiplatelet therapy?
Yeah, okay, so this is a difficult question. There is no, I wouldn't say there's no evidence, but a lot of it depends on your experience. as a rule of thumb, even in the trials, they divide it into less than 30% of the infarct area. If there is a, if it's just a, if it's just staining of it, it's called hemorrhagic transformation. If it's confluent together of more than 30%, there's hemorrhagic transformation 2. And then there's PH, which is a hematoma, it's a parenchymal hematoma, where it's actually very confluent. So if it's basically if it's just a bit of staining, less than 30% of the infarct is safe. If it's more confluent, you tend to be a bit more worried and may want to hold off your antiplatelet and anticoagulation. Having said that, that was a research tool. There are actually a lot of automated measurements of when you should emerge into clinical relevance. So in the end, it's still just a judgment call.
Okay, sure.
Okay, so in the middle of the night, if you're worried, you should just hold it off, and then the next day the team can come and reinitiate it if they think it's okay.
Okay. Then this is a bit of a side question to this, because MRIs tend to be very sensitive in picking up some of these changes. So we have some of these patients who had a CT scan, let's say done in ED, and let's say clinically is very convincing of, let's say, subcortical stroke, but at that point in time, the CT doesn't show anything. Do all of these patients need to get an MRI done, or is a TCD, ECD with the clinical diagnosis of a stroke being clear adequate for evaluating these patients?
Okay, so it varies from consultant to consultant, but I think that as long as if your physical examination is correct, your CT scan does, let's say it doesn't really show a lacunar infarct, your TCD, ECD doesn't show any stenosis, then and the patient has risk factors for a lacunar infarct, then that's fine. It's a coherent story.
Okay.
But if you want to prove it, an MRI is not wrong also. So I think both ways are fine as long as it's a coherent diagnosis and everything is in the correct where it should be. You do not need an MRI.
Okay, sure. So I'll move on to some sort of out of stroke questions. So the first is this question about doing a CT brain for giddiness throughout posterior circulation stroke. This is something that is often done. So at the same time also there are people who say that the CT brain is not really the best modality for evaluation for the posterior circulation. So what is your take on this?
Yeah, so I think it's more medical legal than anything. A CT scan is not going to show you very much. The physical examination is much more important. It should be either MRI or nothing. But I guess it can help to rule out bleed. So if you're worried, you can start antiplatelets. But generally speaking, you're right. CT scan is not so useful.
Okay, sure. And the next would be this one where sometimes a scan is done for an alternative purpose, and we pick up incidental lacunes. Sometimes they said old infarct, sometimes some microvascular ischemia. So how do we make sense of this terminology, and then are they considered strokes, and do we then initiate the full stroke treatment for these patients?
Okay, so this is also it's a gray area. There's quite a lot of research done into it. The underlying theory is that antiplatelet treatment for these patients are actually not indicated because it's still considered primary treatment. Whereas secondary treatment is you must have some symptoms and then you treat it. What everybody agrees upon is that you should still treat the underlying risk factors, which is your diabetes, hypertension, and high cholesterol. So reducing this is fine. Your antiplatelets actually, at this point in time, number one, it doesn't factor very heavily into your stroke prevention. Number two, it's been shown that the benefit and the risks are sort of balanced. So I would say control your blood pressure and control your cholesterol.
Okay, and it doesn't really matter whether it's lacunes, old infarcts, or microvascular ischemia. To you, it's just go for the cardiovascular risk factors. That would be
cardiovascular risk factors, and if you're worried, just do the imaging of the neck and the brain and see if there's anything.
Okay, sure. Okay, maybe before we move on to the take-home points, just one last question about maybe like TIAs, right? So which TIAs need to be admitted to hospital versus just sending back home with follow-ups?
Okay. So we have a very good TIA service run by the nurses. They're very sharp. Basically what we're looking for is high-risk patients, which is large vessel occlusions or large vessel stenosis. Those are the ones we admit. Even atrial fibrillation, if the stroke, if we don't see a large infarct, we send them home on anticoagulation. So basically, the high risk ones are the ones with either no bleeding at all and no large vessel stenosis or occlusion.
Okay, understand. Okay, and finally, as we wrap up now, maybe you could just highlight any pitfalls or any take-home points for the residents to pay attention to when it comes to diagnosis and management of stroke.
I think basically acute care is very important. So a lot of times in hospital strokes it's widely reported that the time to treatment is very long because people tend to dismiss the fact that the patients are already in hospital and they responded to slower. So really, if there's a suspicion there's a stroke, you have to get to the patient as fast as possible because time is brain. When you see a stroke, the first a new stroke or a patient is suspected of stroke, one of the only things you can do besides sending a patient for a CT scan is check the blood sugar level. So very often the blood sugar level is very low or very high, and you reverse it, and the patient immediately recovers. Okay, so that's very commonly done. Otherwise, if not, just rush. Feel free to call the registrar. They might scold you, but really this is your one window in which to make sure that the patient has independent function for the rest of his life. Yeah. So it's worth taking a little bit of scolding. It's no big deal.
Okay, sure. Thanks a lot, Dr. Leonard. I think it's been very helpful. So thank you very much for your time. Sure.